Hello, I'm Matthew Balti with the Acoustic Neuroma Association. I'd like to welcome everyone to the 2024 ANAwareness Week presentation of post-treatment hearing rehabilitation with Dr. Courtney Voelker and Dr. Rebecca Lewis of Pacific Neuroscience Institute. You can stay up to date with ANAwareness Week and everything the ANA has to offer at anausa.org. Our website is a great resource for so many topics you may have an interest in. There's a search function so patients can find just what they're looking for. Lastly, keep an eye on our social media pages, Facebook, LinkedIn, Instagram, Twitter, for more information and resources. The ANA is here to help, so please access those opportunities. So Dr. Voelker and Dr. Lewis, if you'd like to turn on your camera, share your screen, and introduce yourself, we can get started.
I guess I can introduce myself first. I'm Dr. Rebecca Lewis. I'm an audiologist, and I'm the audiology director of our adult and pediatric cochlear implant program at Pacific Neuroscience Institute. And I'm here to talk to you about treatment post-acoustic neuroma removal surgery with Dr. Courtney Voelker, who I will let introduce herself as well.
Okay, so hello, and we are very happy to be here. I am Dr. Courtney Voelker, joined by Dr. Lewis, and we are from the Pacific Neuroscience Institute, and the Acoustic Neuroma Association has asked us to speak on post-treatment hearing rehabilitation, which is a very important topic to our patients and us. We are located in Los Angeles, California. We have started a novel program to serve the acoustic neuroma population, lateral skull base surgery. And under that, we have launched a hearing restoration and cochlear implant program to serve the needs of our patients. So this is our team. I am the lateral skull base surgeon. We have Dr. Lewis, who's in charge of our cochlear implant and hearing restoration program. We have David, who's our cochlear implant coordinator, and Rose Angelica, who is our surgery coordinator. And this is all possible because of Dr. Griffiths, who's the founder of PNI and the visionary of our program. So just very basically to talk about the ear, since this is patient-centered, as you all will learn, the ear is a center for both hearing and balance, which can be affected by vestibular schwannomas that usually grow on one of the two vestibular nerves. The vestibular schwannomas start growing very small. They start in the cannula or the intracannulicular area, and then usually slowly grow. Here is a schematic of how the tumors can grow, and the tumor cells originate from the Schwann cells that insulate the nerves. What are the characteristics that affect post-treatment hearing? Well, the number one indicator of what your hearing is going to be like after treatment is what it was like before treatment. So bad hearing before is usually bad or worse hearing after. Number two is the size of the tumor. So the larger the tumor, this is not always the case, but the larger the tumor, usually the worse the hearing after treatment, either radiation or surgery. And then how close is the tumor to the cochlea in the internal auditory canal? So is there fundal fluid, and what is fundal fluid? So there is fluid in the internal auditory canal that surrounds the tumor. And as surgeons, we measure the distance between the cochlea and the rest of the tumor. And if there is a large area between the mass and the cochlea, that is a better indicator for how your hearing will be after treatment. Okay, moving on here. So thank goodness that we no longer have hearing amplification devices such as these. This is one of my favorite slides. You know, back in the day, this is what patients relied upon when they had difficulty hearing, and thank goodness we've moved past that a bit. Dr. Lewis will talk more about cochlear implants as a device, but just very briefly before we get into that, This is sort of what one of the company's implants look like. This is the electrode that goes into the cochlea organ itself. And this is the external component that the patient would wear on the outside that is an electromagnetic device. So just briefly, many of you may be considering surgery and what type of approach and how that would affect your hearing and other symptoms. We're only talking about hearing today, but medium to large size tumors with poor hearing, surgeons are usually going to be speaking about the retrosigmoid or the translabyrinthine approach. Now, when I was being trained, hearing options during surgery were not really spoken about. But more recently, as a field, we are asking the questions, can we restore hearing through cochlear implantation at the time of the tumor removal? This would be done through a translabyrinthine approach and is usually reserved for folks that have extremely poor hearing before the surgery. There are a lot of caveats to this in the fact that although cochlear implants themselves are not, experimental, we are still learning which patients, which tumors, and which surgical techniques will get the best outcome if we place a cochlear implant at the time of tumor removal. So just briefly, poor hearing is usually translabyrinthine approach. We make the incision behind the ear, lay the ear forward, and approach the tumor from behind the ear. And what about hearing preservation approaches? So what if you're a patient that actually has serviceable hearing, and what does that mean? Can I understand over the telephone? That's a great screening question for not only doctors, but also for the patient as well. Can I understand using my tumor side what people are saying over the telephone? And that is usually what we call serviceable hearing. If a person undergoes a, quote, hearing preservation approach, which are the middle cranial fossa approaches for smaller tumors, or the retrosigmoid approach for the medium to larger size tumors, our goal there obviously is to save the hearing that you have. So what is the middle cranial fossa approach? That's the approach for smaller tumors that are in the cannula. We in the internal auditory canal itself, we make the incision above the ear and approach the tumor from the top, trying to basically peel it off all of the important cranial nerve structures. For medium to larger size tumors with good hearing, we use the retrosigmoid approach. Those are for 1 to 3 size tumors, 3 centimeter tumors. And we do a similar surgical incision as the translabyrinthine approach post-auricularly. So although our goal during the surgery is to save your hearing, sometimes the hearing is either degraded or is lost altogether. Now, we can offer cochlear implantation as a second surgery after hearing is lost. The real question is, how quickly do we need to do that? How soon is scarring and fibrosis setting in before we could not get the cochlear implant electrode into the cochlea? And those are still questions that we're asking in our field. Also, after radiation treatment, a lot of times hearing is lost in those patients, and we're starting to ask our question, are cochlear implants good for those patients? And while as a group, post-radiation patients do not perform as well as those who have not had radiation, we have had a lot of patients that have had great success post-radiation with a cochlear implant. And so with that, I'm going to stop sharing my screen and hand things over to Dr. Lewis, and she can take it from here.
Okay, Thank you, Dr. Voelker. So what happens if hearing decreases? So Dr. Voelker was talking about serviceable hearing. So we're talking about the hearing's decreased, but is still serviceable. There's sort of this 60-60 guideline that we like to think about. So just to start to get our surroundings, this is an audiogram. This is how we plot hearing on a graph. So the top axis represents frequencies, kind of like keys on a piano going from bass to treble. And then the vertical axis represents loudness, going from soft like a whisper to loud like a jet engine. So higher on the chart is better hearing than lower on the chart. And this gray bubble actually represents where normal speech is. If we're not yelling or whispering, this is where all the different speech sounds fall. So F and S sounds are sort of high pitch but soft, and vowel sounds are a little louder but lower in pitch. So when we look at hearing levels, this might be a patient that we would try a hearing aid on first. So the 60-60 guideline looks at, on average, is there about a 60 decibel hearing loss? So this looks about that. And then also when we test a patient in the booth doing an audiogram, we also look at their speech perception results, meaning how well can they understand words, repeat words. And if they're performing at 60% or better, we would strongly encourage a hearing aid trial. At least in the state of California, there's a 45-day trial window where you can get a full refund for your hearing aids. So we would at least recommend giving it the college try first. But what if hearing is completely lost? We refer to this as single-sided deafness. So basically all the hearing is gone in one ear. So there are several options for us to jump into talking about. There's no treatment, of course, which is easy on a patient, no surgery, but you have to suffer the full disability of hearing only with one ear. We're going to dive into each of these individually, but the cross and bicross are hearing aids, and they really only help you with alleviating the head shadow, which basically means that if somebody's talking to you on your bad side, it's softer by the time it reaches your better ear. It makes it really hard to communicate. So when you have only one hearing ear, it's impossible to locate where a sound is coming from. We use microsecond timing in the ears to identify where a sound is coming from. So with cross and bicross hearing aid systems, you don't have those localization tools to your advantage. Same with bone conduction. You still can't localize where a sound is coming from. There's also a lot of benefits to having two ears. We hear an extra few decibels of loudness when we have two ears. So there's these binaural hearing benefits, hearing with two ear benefits. And also our brain, it spends less energy discerning speech from noise if we have two ears. So there's this added benefit of something called binaural squelch, meaning our brain has an easier time interpreting speech in a noisy environment. So there's a lot of benefit to having two ears. So the cochlear implant is, of course, one option, and it's a great option because it offers those binaural hearing benefits. So it's the only option that can restore hearing to the ear that lost all of its hearing. So if the cochlear implant is great if the hearing is lost, but the nerve, the cochlear nerve or the cable can be saved. So the cochlear implant does not work unless the nerve is intact, because basically the cochlear implant replaces the sensory system, and I'll show you in a second, but it still relies on the nerve to send the cochlea to the brain. There are variable outcomes, but it's worth a try for binaural hearing with very little risk. As Dr. Voelker spoke about, sooner is better than later, mostly because of the potential scarring and fibrosis that can occur following the tumor removal. And she also discussed, some of the factors that can affect preservation of hearing following acoustic neuroma surgery, including the size and placement of the tumor. So cochlear implants and single-sided deafness have definitely been recently studied quite a bit. It's a little bit different, the variable outcomes with acoustic neuroma surgery, because that nerve has compromised a bit. And of course, there's variable outcomes because there's variable size and placement of tumors, right? One thing that a lot of patients have that have acoustic neuromas is tinnitus, which is this loud, sound in the ear can be roaring, it can be crackling, some people say crickets, and it can be pretty devastating for some people. Cochlear implant usually alleviates that symptom of tinnitus because that sound in the ear can mask over that ringing in the ear. There's obviously a lot of auditory benefits. It takes 2 ears to make a thing go right. So by having 2 ears, you can localize sound again. You have an easier time hearing in noise. You get that added boost. So even if it's not just for speech understanding in the ear that couldn't hear anything, there are these other benefits, and that localization and feeling like you have more spatial awareness. We know that when there's single-sided deafness, there's greater risk of falls as we age. So having the ability to spatially hear is really important as we get older. There are psychosocial benefits as well. So there's decreased listening fatigue, basically, when you have 2 ears. You're not thinking about, where am I sitting? How am I positioning myself in the right space because I have one dead ear? And this can, of course, using all that cognitive effort to do other things can affect your short-term memory. So having 2 ears helps with all of that. And of course, an improved quality of life and social interactions. So the cochlear implant has a few basic components. The speech processor that's worn on the outside has microphones that collect the sound and convert the acoustic sound to a digital sound, which is sent to the coil that's on the head. And then the coil is held in place by a magnet that's right underneath the skin. And that's there to just simply align the 2 coils so they can communicate. And then the receiver stimulator collects that signal and stimulates the implant in the cochlea. So you can see it sort of winding in the cochlea right there. So those electrode arrays replace the damaged cells in the cochlea, and they stimulate the nerve directly. So the nerve then receives the signal from those electrical contacts, and that's what gives your brain that perception of sound again. So when you take it off, you hear nothing. And when you put it on, you can hear again. The battery, the power source, it's all on the outside. Today, we have the benefit of having 3 very good cochlear implant manufacturers that are always innovating and creating better technology, and they always make the technology for the outside backwards compatible. So as people get older, they can benefit from new technology and upgrades without another cochlear implant surgery. So moving on to if the nerve is compromised, if we can't do a cochlear implant in that ear, or if the patient doesn't want to have a second surgery or the implant placed at the time of surgery, cross and bicross hearing aids are also an option. Cross stands for contralateral routing of the signal. So this image here shows basically if you're wearing 2 devices, 2 hearing aids, so you do have to wear something in your better ear. And if somebody talks to you on your bad side, it wirelessly transmits the signal to your better ear. Bicross is basically if your better ear has some hearing loss, the sound will still get picked up by the opposite side, transmit to the better side, and give some amplification to the ear with hearing loss. So it's a hearing aid plus it's receiving the signal from the opposite side. This does not help with localization. It does help reduce the head shadow effect, so you can still hear people that are talking on your bad side and reduce listening effort in most situations. Hearing aids are not covered by insurance. I should add cochlear implants the surgical devices are covered by insurance. Hearing aids have varying degrees of benefit for different insurance plans, but they're not covered by Medicare. Another thing that these cross hearing aids now have are these remote microphones, and you can see the little picture of this clip-on mic over here. That can really help in noisy environments. Sometimes in a noisy environment, the cross is not beneficial because you're just flooding the ear, your only ear, with noise from both sides. So by handing the clip to your friend, they can wear it on their shirt and their voice goes directly into your ears, which really helps in those noisy environments. Another type of hearing aid, and this is a hearing aid that you can wear on the skin. It's a little sticker that's supposed to last about 5 days on the skin, and then you snap the hearing aid onto it. You have to have perfect hearing, normal hearing in your better ear for this to work, and it works through bone conduction. Basically, our cochlears are both encapsulated in bone. So if you stimulate the bone on one side, it'll stimulate the better hearing ear immediately. So you wear it all day and you put the sticker on once a week. The issues we have with this are retention. A lot of times the sticker doesn't stay on perfectly. You do have to kind of find the sweet spot for this to work. The benefit is that nothing is being worn in the good ear, especially if it's totally normal hearing in the better side. There are other devices that work really well through bone conduction, and they're osseo-integrated devices. Some of them protrude through the skin and some do not, and we're going to dive into that. So bone-anchored hearing aids are often called BAHAs, bone-anchored hearing aids. You need normal hearing on the other side under these circumstances for these to be helpful. And again, through bone conduction, this device snaps into the skin or snaps onto the abutment and sends a signal to the better hearing ear, only reducing the head shadow and reducing listening effort. And again, in noisy environments, still you might end up using one of those remote microphones that are also compatible with all of these devices. So one of them, we talked about protruding through the skin or being transcutaneous. This is what the abutment looks like. And if you look at this diagram, number 3, that's the implant that gets osseo integrated into the bone. And then the hearing aid device snaps on to that abutment. And it is a hearing aid. It works entirely through mechanical energy. So there is greater risk for feedback. And of course, with the device protruding through the skin, there's some risk for infection. It does create a really stable sound, and a lot of patients over the last 20 years or 30 years have used these and been very successful. But there are actually newer options that don't have anything going through the skin. One of them is called the Baha Attract. So it's the same hearing aid you can see, but instead of the abutment going all the way through the skin, it has a magnetic plate. So a magnetic plate is worn on both sides, and then the sound is sent through, again, the magnet and then bone conduction to the better hearing cochlea. The issue with this one is that the amount of amplification for higher frequencies is a little less stable than the direct connect. These are probably the more popular ones that we do now. You get a lot of great sound quality, even those high frequencies. There's very low risk for infection on these because nothing's going through the skin. And there's less feedback because they use something called piezoelectric technology. So basically, this device is under the skin. This is integrated into the bone. And just like the cochlear implant, the outside part is held in place by the magnet. So it collects the sound, converts it into this electrical energy that's then converted back to the mechanical energy to stimulate the better hearing ear. This one is approved for 5 years old and older. The Ossia is developed by Cochlear Americas, and then the Bone Bridge is developed by Medel. It basically works the same way, only this one we can activate a bit sooner. It doesn't take as much osseo integration because you actually end up with a slightly bigger well in the bone that Dr. Voelker would make. And then the MRI compatibility is a little bit different because there's a magnet under the skin. But these are both really great options to help people through bone conduction, especially if they don't have the advantage of using the nerve for a cochlear implant. So that's our presentation here about acoustic neuroma and our rehab strategies for these patients. And we look at each individual and try to work with each patient to identify what they're comfortable with and what is appropriate for each patient.
Great, Dr. Lewis and Dr. Voelker, thank you so much for your time. If you want to go ahead and stop sharing your screen, Dr. Lewis will hit into a few questions we have from some patients. A lot of this we probably already touched on, but it's nice to hear some specific questions about some different things. So we'll go ahead and jump into this. We have a patient who had radiation almost 2 years ago now, and they talk about having a constant ringing and static noise that started shortly after treatment. Loud environments cause that to be more intense and last several days. Are there any precautions they might be able to take to prevent or lessen the intensity of that ringing?
Well, I'll start and then Dr. Lewis can jump in there. So You know, this is one of the issues with radiation. You know, we love to wish that radiation is just kind of a one-time treatment, stops the tumor growth, has no side effects at all. The person's, on the golf course the following day. But we know that's not true. We know that unfortunately radiation is the gift that keeps on giving. This is why it's such an important modality of treatment for all types of growing tumors in the body, is that the radiation effects continue to contribute in the body and have a negative effect in the body for actually, years and decades to come. And we know that when we follow these patients, they can have damage to their hearing apparatus, with hearing going down over time, with tinnitus, which is, the number one cause of tinnitus is hearing degradation, and vestibular effects. A lot of times when you follow post-radiated folks, imbalance becomes an issue. And so tinnitus is tough. So tinnitus is, as I mentioned, the number one cause is hearing degradation. I like to explain it to patients that it's like a phantom limb syndrome of the brain. So, phantom limb syndrome is when you have a limb cut off. Some of those patients actually feel like they still have a limb, and they feel pain of that limb, of their hand. They swear it's still there. And that's because the default mechanism of our brain is to fill in the missing gaps. It's actually a survival mechanism of the body, is, you know that you had a limb, that you had hearing, and now the hearing is going away. And the brain says, wait a minute, I'm going to fill in the missing gaps. And so, number one, Becky can talk about this a little bit, but the number one treatment to decrease that phantom ear tinnitus is to give back the brain the hearing. So most likely that patient that wrote in probably has degradation of hearing as well. And so you want to give back the brain the hearing through hearing amplification of all types, either regular hearing aids, cochlear implants if the hearing's really bad. And then modern hearing aids actually have tinnitus reduction programs built into them. And Dr. Lewis knows a little bit more about that if you want to kind of jump in and talk about that.
Sure. I mean, that pretty much covers it. So some of these hearing aids have tinnitus maskers in them. So you can, with your audiologist, you can identify the frequency and level of your tinnitus to try to find the appropriate masking sound. You can make noise notches around the tinnitus. You can try to match the tinnitus and use the lowest level that gives you relief. Sometimes doing that a little bit a day and reducing it every day can help sort of tinnitus retraining therapy in a way. Lots of patients, will do, sort of meditative or breathing techniques to try to keep their reaction to the tinnitus lower, because we know it can be pretty severe sometimes. If there's not a lot of hearing loss, there are apps out there that do the same thing, that are these noise notch type apps where you can create the noise that you want. You can even use the Calm app and do the ocean or something that's pleasing to you with an AirPod or a headphone in that ear, or a fan at night, if that helps too. So again, like Dr. Voelker said, it's really filling in that gap usually is the thing that helps the most.
Great. We've had someone write in who has had a neuroma for about 13 years now, and it's shown very little growth. But since taking a plane ride, they've had some decreased hearing, specifically in their ear where they have the neuroma growing on. Because of no other symptoms, they've been advised to just stick with observation for now. So they're looking into some hearing aids. So they're asking about, should a doctor of audiology be seen for hearing aids, or is a licensed audiologist okay for helping you pick out a hearing aid, or what option might be best for them?
I guess I can start. First, if there's been a change in hearing, an audiologist needs to refer to ENT, to their surgeon or their ENT immediately. So as soon as they note any kind of change in hearing, that's the first stop. And if you tell a clinic or tell an ENT office that you have a sudden change in hearing or an increase in tinnitus suddenly, they'll see you immediately because it's an emergency. So that's step one. And then I think that patient might be asking about the difference between a hearing aid dispenser and an audiologist. Hearing aid dispensers, some of them are really great. They just need a certificate. They don't need to go through rigorous training, but they can dispense hearing aids, and some of them do it really, really well. An audiologist goes through a 4-year doctoral program and learns everything basically there is to know about the ear and hearing and rehab and cochlear implants and hearing aids, and the list goes on and on and on. So if it's something more complicated like monitoring a neuroma plus drops in hearing, I might advise them to see a licensed audiologist or a doctor of audiology instead of a dispenser in that case. But there are good dispensers out there too.
And I would just add to that oftentimes, even if I don't see a tumor growing, but patients have drops in hearing, patients may actually respond to a burst of steroids. So particularly if there was an event associated with the drop in hearing, such as this patient with a plane ride, change of barometric pressure, atmospheric pressure, barotrauma, those sorts of things. It doesn't work in all patients, but oftentimes I'll give a patient a burst of steroids, and sometimes the hearing can pop up. Obviously, we know why their hearing is going down, is there's a tumor there, but it's not going to be a permanent fix necessarily, but oftentimes we can get the hearing to come back up with some medication. I would agree that absolutely a patient needs to see a properly trained audiologist. Hearing aid dispensers are more sort of for run of the mill. I like to tell patients that the ear is very similar to eyes. So, you need a pair of readers that you pick up at CVS or this or that. That's sort of where the hearing aid dispensers come in. Run of the mill, we're getting older, a little bit of hearing loss, can't quite hear at parties, that kind of thing. But when you have a tumor that's associated with your hearing loss, you really need extremely educated professionals. So I would really encourage that patient to be followed closely by a surgeon as well as their audiology partner.
Great. We have a musician who was diagnosed with a 2.1 centimeter acoustic neuroma, and they've already lost some hearing on that side. And obviously, they're wanting to know how to preserve their remaining hearing because of their profession. So they're asking which type of surgical procedure might be best for them.
Yeah, first of all, how do you know which approach? So the very first thing you look at is the patient. So, you look at how old this patient is, how many years that they have ahead of them, hopefully, what their underlying medical conditions are. All the surgical approaches that we do are tough on the body. And so you want to make sure that the person is healthy to go through the procedure. And then you look at the symptoms that the patient has. So this goes back to what we were talking about initially, is serviceable hearing. So it's sounding like, from how you describe the patient, that they have serviceable hearing, that they have pretty good hearing, and that it's just starting to go. Also, is the tumor growing? So if the tumor is not growing, then you can continue to monitor and you can continue to see what's going on there. The hard part for both the surgeon and the patient is that even a growing tumor, the hearing can go. So I have had patients that were monitoring even very tiny tumors, and a handful of those patients can have a sudden loss of complete hearing. And obviously that is devastating. So when I'm talking to the patient, I say, what is the risk of watching and waiting? Really, the only risk of watching and waiting is you could be one of those folks where even if the tumor doesn't grow, you could lose all your hearing. And so now you're back to a musician who really wants to preserve the hearing. Even in a non-growing tumor, one may entertain surgery as the best chance of saving that hearing. We know if you radiate that patient, that over time, decades that we've talked about, the hearing will probably be compromised. And with a 2.1 centimeter tumor, again, I'd have to look at the images and see how close it is to the cochlea and where is it located near the brainstem. These are all things that we look at as a surgeon. But 2.1 is sort of over the edge of what most people would feel comfortable with the middle fossa approach, and you're probably looking at a retrosigmoid approach. But again, all of those things need to be looked at with your surgeon.
Great, thank you. And I think we have time for one more. This person says they found the hearing test that they had before and after surgery varied from the ENT to the audiologist. Is that variance possibly due to machine or operator, or just how it might be read?
So the hearing test sounds like it was different at the ENT's office that has an audiologist versus their personal audiologist. That is interesting. That I guess can happen from time to time. I would recommend, repeating the hearing test again with the ENT's audiologist. They're maybe more familiar with post-operative surgical hearing losses that are a little bit more complicated. Audiology equipment should be calibrated, so there shouldn't be big discrepancies, frankly, between offices in a short period of time, unless there's some change in the actual hearing itself. But I would just recommend to stick with the ENT audiology test.
Yeah, I would echo that. When you see great discrepancies in hearing tests, that's always a big question mark. So, you don't take one test in isolation, you look at patterns over time. And, an audiogram, a basic audiogram is actually not very easy to do. So you need to test each ear in isolation. If there's a conductive component, you need to put masking in this ear and that ear. I'll just stick with surgery. Thank you very much, because it's actually Becky's job is very difficult. And when you have a skilled audiologist that can really get at the heart of each ear's hearing, that is really important. And I do, as I see patients coming through our clinic, there's a huge variation in the skill of an audiologist. And to echo what Becky's saying, an audiologist that's working with an ear surgeon is seeing a lot of complicated ear patterns that sometimes in the community, and especially perhaps in underserved or underpopulated communities where they're not seeing a lot of pathology coming through, it's really important that you have a skilled audiologist that works closely with a surgeon. So if there's any question at all, like Becky says, always get it repeated by a higher level care audiologist, and show it to your surgeon for any questions that may arise.
Great. Well, Dr. Voelker and Dr. Lewis, thank you so much for your time today, for sharing your great knowledge with us and answering some of the questions. We're grateful for what you all do for acoustic neuroma patients, and we're grateful for your and P&I's partnership with the ANA.
Thank you for having us. We hope this is helpful for the patients.
Thank you so much.
Absolutely. Okay.